All right, everyone, it's 9 o'clock, so let's go ahead and get started. Thanks everybody for joining in on this audiology lecture. I'm Jennifer Shinn. I'm the Chief of Audiology and an Associate Professor here at the University of Kentucky. And today we're going to be spending the next hour talking about auditory processing for the otolaryngologist. All right, just some quick disclosures. I'm paid by the University of Kentucky. I do receive royalties from Plural Publishing for our book on disorders of the auditory system, and I do have NIH funding. So just to go over a brief outline of what we'll be talking about today, there's a real clinical dilemma that we all face, and we'll talk about what that is, but it's related to patients who have normal hearing but have some pretty significant auditory complaints. And we'll be talking about how we can actually evaluate patients for auditory processing disorders and manage those disorders if they're identified, how processing can relate to very specific patient populations that we encounter on a daily basis. And we'll finish up the lecture today with some case examples of patients that we've seen in our clinic over the years. So I'm going to go over some statistics with you to begin. The first statistic is one that we're all probably very familiar with. Approximately 38 million people in the United States have some degree of hearing loss ranging from mild to profound. But the statistic that I think we're less familiar with is this one that states that an additional 26 million Americans or adults specifically possess hearing thresholds within the range of normal limits, but they too complain of hearing difficulty and speech and noise problems specifically. This is data from Doug Beck's group. And that's really what we're going to be talking today, is this second group of patients that have normal hearing but hearing complaints and what we can do for them. So this is the clinical dilemma that we face on essentially a daily basis here at UK. We have a patient who presents with complaints of hearing loss, specifically hearing and noise. They often know that they're very tired at the end of the day. They're experiencing headaches. This is likely a result of greater listening effort on their part. Yet, when we evaluate them audiologically with a traditional pure tone audiogram, this is what we find. They present with normal hearing sensitivity or acuity. So what we need to consider is that this person does not actually have normal hearing in spite of normal hearing sensitivity. And we have to think about how we actually define what is normal hearing. So I want to go over some definitions just to kind of set the stage for what we'll be talking about. Let's kind of first start out with this general idea of auditory processing. And ASHA defines that as the efficiency and effectiveness by which the central auditory nervous system utilizes auditory information. Neuroaudiology is really just the study of the brain as it relates to hearing. And the definition I like to use, especially with patients and with parents of patients, is it's really what we do with what we hear. And this is really an important thing for us to consider in an otolaryngology practice. We're not going to spend a whole lot of time on this slide. It is very busy, but the take home I want you to get from this slide is that hearing goes well beyond the cochlea. You know, we're used to working in the middle ear and with the cochlea, and there are things that we can surgically correct. But there is a significant part of the brain that often gets forgotten about, and that is the central auditory nervous system. And all the way from the pons up to the auditory cortex and subcortex, there are critical pathways and nuclei that are important for us to be able to efficiently and effectively process auditory information. There are a number of possible causes of non-peripheral involvement that can result in auditory complaints. This can range anywhere from neuromorphological abnormalities. Galaberta in the mid-1980s identified groups of ectopic cells on postmortem studies of patients with dyslexia that were specifically in the left primary auditory cortex. We know that this may just be a result of a neuromaturational delay, or it could also be a decline. We know that as we age, we really reach peak myelinization at around the age of 20, and then we do continue to have a decline in our myelin, specifically at the level of the corpus callosum, as we continue to age. So in our anywhere from our 60s to our hundreds, our brains are not as efficient and effective, and so that could result in some abnormalities as well. We know that for a lot of these patients, there's just frank neurological involvement, whether that is a stroke, either diagnosed or undiagnosed. It may be an agenesis of the corpus callosum. It could be a demyelinating disease, such as multiple sclerosis. We have studied estrogen and its role in the auditory system, and we'll talk about that a little bit later in the presentation. But unfortunately, sometimes we just don't know what causes these problems, but they are real, and we need to help our patients work through them. So I'm going to go over a little bit about hearing complaints in individuals with actually normal hearing sensitivity. So this is some unpublished data by Frank Music, and he examined 40 patients who had symptoms of auditory complaints, yet they had normal audiograms. And on those 40 patients, it was a fairly even split between males and females, and they were young. They were in their late 30s, that was the mean age. And all of these individuals had lesions within the central auditory nervous system. Most of them were in the cortex or subcortex, but there were 6 individuals with brainstem involvement. And what he found was that in those group of 40 patients, 78% of them had an auditory complaint of some kind. And if we actually break down what those complaints are, 33% of them reported difficulty hearing a noise. About 45% of them reported some kind of difficulty with discriminating or some kind of a distortion of an auditory signal. 20% of them had a change in their musical appreciation, 10% demonstrated difficulty localizing, and then there were just some kind of other generalized complaints in a small portion of the population. So we need to keep in mind that if we do have a patient who comes to us and they do have a history of some kind of frank lesion within the central auditory nervous system, there is a high likelihood that they will have some kind of an auditory complaint that needs to be further investigated. I think the thing that's important to keep in mind is that often, particularly in our patients who have had a stroke, that immediately following the stroke, they're not considering their auditory system, even if they do have significant auditory involvement secondary to that stroke. And that is because they often have other significant impairments such as physical paralysis, and that's really what they're focused on. We often see in our clinic that 6 months to a year after the incident, they start to complain to their neurologist or their primary care physician that they're having difficulty hearing in one ear or the other. And that's when they usually end up in our clinic fairly far out from the actual stroke or damage occurring. When the same group of patients were examined and we looked at how they actually did on a battery of central auditory processing tests, only 8% of that population actually passed all tests and would have been considered to be within normal limits. 92% of them failed 2 or more tests, and it's important to keep in mind that because of the criteria for actually diagnosing an auditory processing disorder. So in order to receive that clinical diagnosis according to the American Academy of Audiology guidelines, you have to fail at least 2 tests, or you have to fail 1 test by 3 or more standard deviations. And actually 1/3 of those patients of that group of 40 failed all of the tests across the battery. So this just speaks to the ability of the central auditory tests to actually detect these abnormalities in a population with known lesions within the central auditory nervous system. Several years ago, in 2015, we were really curious about this population of patients because we saw many patients coming into our clinic with very clear auditory complaints, but when we evaluated them, they had normal peripheral hearing sensitivity. So we investigated we did a retrospective chart review, just under 500 patients who didn't have any active otologic involvement, but they had complaints of either hearing loss, auditory processing deficits, or they complained of tinnitus. And you can see that nearly half of the patients that came into the clinic were very clear in stating that they had some degree of hearing loss. However, when we evaluated them, they had normal hearing sensitivity. When we actually break out the data by age and by number of participants, we see that the majority of these patients, again, have hearing loss. And if we look at it a little bit further and we break this out by gender, this is where the data gets interesting. We see that most of the patients are female, and most of the patients are in the range of 30 to 60, which also happens to be the range of when women start to become peri and postmenopausal. So this really got us thinking, what is it about this population that is yielding more complaints and difficulties and potential abnormalities on test results? So really what we surmised from this study is, one, we needed to investigate this further, but two, this hearing loss that these patients were complaining of was more than likely an auditory processing deficit, and that these patients really needed to have a full evaluation to further elucidate those problems. So this is a very typical patient that we see in our clinic, often middle-aged female. They have significant stressors in their family, in their life, oftentimes busy families, big families. They may have difficulty at work. It's not unusual for us to see professors in our clinic who are really having difficulty hearing their students. They all almost report that they are extremely tired at the end of the day, suffering from headaches, and they're having difficulty hearing in these challenging environments. So it got us to thinking, what is it about these patients? There has to be something potentially chemical or hormonal going on. And so that's when we started to look into this idea of estrogen and hormones playing a role in the hearing in this particular population, because it is such a large population for us here at UK. In 2013, when I did my first literature search on estrogen and auditory in PubMed, there were 168 articles, which actually blew my mind. I didn't realize at that time that there was so much published data in this area. And when I was putting this lecture together a few months ago, I reran the lit search, and there were up to 262 articles. So this is clearly an area of interest and is fairly well studied. Raphael Pinode at the University of Rochester studies the zebrafinch, and actually when you look at the data out there, most of it isn't an animal or bird model. There's very little literature in humans to further explore this concept of hormones affecting hearing. But in the zebrafinch, he states that estrogen plays a central role in how the brain extracts and interprets auditory information, and actually goes as far as to say that it is a central regulator of hearing. And so this really matched up with our clinical experience that peri and postmenopausal females were experiencing auditory complaints with actual no measurable peripheral involvement based on their audiological evaluation. So the work of one of our residents here, Dr. Trott, this was a project that he worked on as a medical student, where we actually investigated pre versus peri and postmenopausal women, and we put them through a test battery as well as electrophysiological testing. And what he found in that study really lined up with what we were seeing clinically, is that these patients had poor temporal processing abilities, and they actually had poor morphology on their evoked potential testing. So their ABRs and their latency responses did not look as good morphologically as their patients with that were premenopausal. So I think it really begs the question, and it's something that we all need to think about clinically, is we rely heavily on the audiogram. It is one of our primary tools audiologically, and as otolaryngologists, it's something that you rely on very heavily as well. But we have to understand and appreciate the limitations of the audiogram. It does an excellent job of giving us information about type, degree, and configuration. However, beyond that, it does have limitations. As early as the 1940s, Carlin reported that audiogram was really poor at predicting performance, particularly in complex listening environments. And probably the most referenced and publications in this area are from Boca and his Italian colleagues in the mid-1950s. And what they found was that patients with significant lesions within the central auditory nervous system actually had normal audiograms. However, when you evaluated these patients when there was degraded speech, they absolutely fell apart. And that wasn't identified on the audiogram. So if we relied on that audiogram alone, we would actually miss how that patient is doing functionally. And it really is a poor predictor of hearing beyond type, degree, and configuration of hearing loss. So these are just some symptoms of patients who might have some central auditory involvement that would warrant further investigation. And I'm not going to go through this whole list. You'll have these slides available to you after this presentation, but I just want to highlight the ones that we see the most often in our clinic. And the number one is difficulty understanding speech in the presence of background noise. Now, this is true for both patients with peripheral hearing loss, but also patients who demonstrate central auditory involvement. That's the one thing that they always complain about. They'll also note that they have difficulty following rapid speech, and they often are asking for repetition or rephrasing of information, and will have difficulty following multi-step directions. Just some test principles that I think are important to keep in mind. Really, the audiologists should be the ones who evaluate these patients. They have the training and the skills. However, I will say not all audiologists are trained to do these evaluations. So within your own practice, it would be an important conversation to have with your audiologist if they have experience in auditory processing, and if they don't, perhaps find an audiologist in your area that you can either refer to or try and get your audiologist some training in this area. This is a test battery approach that we take. And it's really, we don't give the same battery of tests to all patients. It's driven by the history that we obtain from the patient. So it's very important to get a really detailed history. All the tests that we administer have good reliability and validity and high sensitivity and specificity. And the audiological battery should examine different processes. So we want to look at what's going on with the periphery, the central process. We want to look at how patients integrate information, how they separate information, how they do in noise. So we look across different areas. You need to be sensitive to the attributes and behaviors of the individual. We don't want to test for hours. We typically want to test children first thing in the morning, and we need to understand what their motivation is, watch for them to get fatigued through testing, those sorts of things. All tests have been normed, and so it's important that the clinicians understand that normative information. And we want to use a collaborative and multidisciplinary approach. We certainly don't want to work as an island because we have to rely on our colleagues for their expertise as well. Test methods should be consistent with original research methods. And we, like I said before, we don't want to test for hours on end. And one of the things I hope that you take away from this is that auditory processing is not just for children. And in fact, I would say 50 to 60% of our practice are adults that we evaluate here at the University of Kentucky. This is just kind of an overview of the efficiency of our auditory tests, but you can see the ones in red are typically involved in the battery, and those have the higher sensitivity and specificity. So let's go over what some of these tests are. Now, this is not meant to be exhaustive. We only have an hour, but I'd like to just give you an overview of some of the more popular tests, some of the more sensitive and specific tests that we here at UK. So let's begin by kind of discussing the purpose of diagnosing APD. One, we want to examine the integrity of the central auditory nervous system and see if we can detect any abnormalities. Is there an auditory processing disorder present or absent? What is that kind of deficit? And that's important because once we know what kind of deficit we have, we can structure appropriate rehabilitation programs. We do not just give a general laundry list of recommendations to patients. We really want to provide deficit-driven therapies for that so that we can most efficiently rehabilitate any areas of weakness that they might have. We do provide environmental modifications such as potentially an FM system, or in our adult population that might be hearing aids. And we'll talk about that a little bit later. And then we can provide them with some strategies to assist with any difficulties that they're having. So as I indicated, about 50%, or probably even more than that now, of our population here in UK are adults. There are a number of different adult populations that we evaluate. They range anywhere from head trauma to veterans, patients who have had no neurological involvement. For some patients, it may be that they've actually had this their entire life, but as they become adults and life becomes more challenging and listening demands become more difficult, they're ready to evaluate it. And at that point, they feel like they've got hearing loss, but it really is just this undiagnosed childhood processing disorder that they've had for a long time. And then as we discussed earlier, the menopause population. So just some things to consider when you're referring for an evaluation. We cannot evaluate children under the age of 7. We just do not have any good normative data below that age. However, I would recommend if you have a parent of a patient or a guardian of a patient who is concerned about an auditory processing deficit, that you obtain an audiological evaluation so that we can rule out peripheral hearing loss, because we have certainly had that happen in our clinic. If you can, it's helpful to get a speech language assessment on children. Again, that's just for children, not for adults. And then on children, we always require psychoeducational testing, and that is to ensure that they have normal cognitive function. We cannot evaluate children or adults with below normal cognitive function. If they perform within normal limits on the test battery, but they have normal cognitive function, we can rule out an auditory processing deficit. However, if they perform abnormally, we don't know if it's because of their low cognitive function or a true auditory processing deficit. There's just no way for us to tease that out. And then again, other things you want to consider in the evaluation is attention, motivation, any kind of medications they might be on. So there's a high comorbidity between ADHD and auditory processing disorders. And so certainly if we have a patient who is on medication for ADHD, we want them to take that at the time of their evaluation. Again, watch for fatigue, hearing sensitivity. We normally do not perform these on patients who have peripheral hearing sensitivity. It can be very difficult to evaluate and tease out the peripheral involvement from the central involvement. And you have to understand the normative changes that occur if you do evaluate somebody with hearing sensitivity, and then understand the patient's native language and whether or not they would have the ability to complete an English test battery. I often get questions about what other things you need to be able to do these evaluations if you're not doing so already. You obviously need a sound suite with a 2-channel audiometer or 1.5-channel audiometer at a minimum, because you're often presenting 2 different stimuli simultaneously to the patient, so it can't be a 1-channel audiometer. You need a CD player or an iPad to route your tests through. All these tests are available, most of these tests are available through companies like Oaktree or Auditech. And actually on some of the new audiometers, a lot of these are tests are preloaded on the audiometers. We actually have all of our test stimuli loaded on an iPad, and we route it through the audiometer, which works very nicely. And then you have to have the tests, which again are very easy to access. And if you have the ability to perform electroacoustics, so OAEs, or electrophysiology, ABRs and MLRs, those can really enhance your test battery as well and provide you with some objective information that you would not otherwise be able to obtain. And so just some basic test principles. Again, they're audiologist administered, but you really need to have an audiologist who has a strong knowledge base in this area. We kind of discussed some of these, so we don't need to go over those again. There are some comorbidities that can occur, and so you just need to be aware of those. And again, this is why you need often a multidisciplinary team approach to help tease out some of these. But there are very clear and distinct patterns that you'll see in a patient with an auditory processing deficit. So for example, if you have an individual with ADHD, if you see bilaterally reduced scores across your test battery, you have to be very suspicious that it's not actually an auditory processing disorder, but attention that is contributing to the results. In a true auditory processing disorder, you'll see asymmetries, and oftentimes the left ear performing more poorly than the right ear across test results. And then these are just some other comorbidities that may occur. There's a high incidence of reading disability in children with auditory processing deficits because the auditory system is relied on significantly for reading. And then obviously one of the questions we get a lot are children with autism spectrum disorder. You can certainly evaluate them if they have normal cognitive functioning. When it comes to a test battery, there are some questionnaires that are available that you can administer if you want to do some kind of a screening beforehand. The APDQ is a nice test, and the SNAP-4 is actually free online. It's just a test for ADHD that sometimes we'll screen with, and then that'll help us with determining if a referral needs to be made. You always want to get a good peripheral evaluation on your patient before proceeding with an auditory processing evaluation. So we'll often get parents of patients or adults calling wanting an auditory processing disorder. And in our adults, we actually will require that they come in for a hearing test first, so that we can ensure that they have normal peripheral hearing sensitivity before we proceed with an auditory processing evaluation. If you feel tympanometry is appropriate to rule out middle ear involvement, we recommend that you do that. And then otoacoustic emissions can also be very helpful, particularly with differential diagnosis if you are concerned that there may be some central involvement contributing to the abnormal audiological thresholds. OAEs can help with that. And then when we actually look at the central battery, we break it down into two subcategories, behavioral and then our electrophysiological test results. We always want to give a dichotic task, which we'll discuss in a second. And then we want to give some kind of either a patterning test or a temporal resolution task to evaluate temporal processing. And then I should be added here, we want to give some kind of a speech and noise measure as well. And then when we're able, we like to do electrophysiological tests on our older children and our adults to obtain some objective information about the neural integrity of the central auditory nervous system. So we're going to go through just a couple of the behavioral tests that we administer here. One of the kind of hallmark tests that really should be involved in every battery is a dichotic task. And these dichotic tasks evaluate binaural integration and separation of information coming to the patient. So they will hear two things coming at them simultaneously. We'll look at this in a second, and they have to repeat everything back that they hear. This is sensitive to cortical pathology and interhemispheric compromise. So particularly if you have an individual with involvement or poor neuromaturation of the corpus callosum, you will see abnormalities on this test. Probably the most popular, one of the most sensitive and specific tests that we have is the Dichotic Digits test. This is a test of integration, and I'll show you an example of that in a second. We can also do the same integration task using spondee words. And then we also like to use the competing sentences test. So the patient hears two sentences coming at them simultaneously, and we actually use this as a separation task. So let's take a quick look at what these actually look like here. Before I do that, I think it's important to understand the physiology of binaural integration of information. So if we look at this brain we have here, we have the right ear and the left ear, and we know that language is for 97% of the population is processed in the left hemisphere. We also know that we have both ipsilateral as well as contralateral pathways. And you'll see that the contralateral pathways are bolder, and that's because they are stronger pathways. There's more neural substrate contributing to auditory responses and competition. And so for any stimuli that is in competition, it actually takes those contralateral pathways. So information presented to the left ear actually goes to the right hemisphere when it's in competition. Information in the right ear goes directly to the left hemisphere. So it actually has what we call a right ear advantage. Because this left information being presented to the left ear has to not only go to the right hemisphere, it also has to cross the corpus callosum before it is processed in our language center. So that is where the term left ear advantage actually comes from. Now, what happens when we have a patient with some kind of involvement, whether it's a discrete lesion or ectopic cells or just a neuromaturational lag? So let's say that this patient has an agenesis of the corpus callosum, or they've had some kind of a right-sided lesion. What you're going to see is that information that's presented to the left ear is actually going to yield a left ear deficit, and then you'll see impairment on your test results. So this is just an example of the Dichotic Digits test. So the patient hears 2 numbers in the left ear and 2 numbers in the right ear, and they just have to repeat all 4 numbers that they hear back. I don't know if this will play or not. We'll try. It doesn't look like it's going to play. That's okay. They're coming at them simultaneously, so it can definitely be challenging. And what I just want to bring your attention to are the actual norms on this test. So we can test down as low as 7. And actually at 11, that's when we consider an individual to have achieved adult norms. So 11-year-olds are considered adults when it comes to auditory processing evaluations. And what you see here is the right side scores for all ages except for adults are significantly better than the left ear. And that is because of the neuromaturation of the corpus callosum. It's just not fully mature. And so we need that corpus callosum to cross information over the other hemisphere. So as it matures, we see that those normative scores start to level out between the 2 ears. And this is just, again, this just shows the maturation of the left ear performance in individuals across ages for dichotic digits, competing senses, and the SSW. These are all binaural integration tasks so that we can see as we age, that left ear performance starts to go up because of the maturation of the corpus callosum. Competing sentences, this is another test that we do routinely, and this is a real challenging task. The patient will hear 2 sentences coming at them simultaneously, and there's a target and a non-target ear. So what makes this a separation task is rather than repeating everything back that they hear, they have to ignore one sentence and repeat the other sentence. But the kicker is here, they have to repeat the sentence that's got a lower intensity level. So this is presented at a softer sensation level than the non-target ear. So that makes it really challenging because of the intensity difference. You don't have as much neural substrate contributing to this response, and it makes it much more challenging. And the patient just has to repeat what they hear in this ear. And this is very close to real life. We know that in any situation we're in on a daily basis, we've got somebody saying something to us in one ear and somebody saying something to us in the other ear. Take the operating room, for example. Perhaps you have your attending speaking to you from across the room in a less than ideal listening situation, and then you have the anesthesiologist telling you about the status of the patient. So you have to be able to integrate when you need to and separate when you need to as well. So really something that we have to do on a daily basis, and that is important to evaluate. So if we look at the norms for patients kind of across ages, we actually can't even do this in 7-year-olds. It's quite a challenging task. And even an 8-year-old only achieves 40% performance in the left ear. And 10-year-olds actually are the near adult norm. So pretty steep maturational curve when it comes to this task. Monaural low redundancy speech tests, they are not necessarily as sensitive and specific, but they really are tests that gives us some good ecological validity. So with these types of tasks, what the patient has to do, they're presented with degraded speech stimuli, and these are presented 1 ear at a time. And what we're really evaluating is how well the central auditory nervous system can take poor information. It's unclear, it is filtered, and unify it into one event and use contextual information to figure out what has been said when that signal is not clear. So those stimuli, again, they're degraded in some way. And this really does replicate a real world environment as closely as we can. And the primary tests that we give in this area are filtered speech, time-altered speech. We'll talk about both of those in a second here. And then speech and competition or speech and noise tasks. So just an example of a filtered word test. We'll have a stimuli where the patient says, the recording says, say the word dog, but we actually filter out low frequency information in that. And so it's very muffled. It sounds like the patient has the presenter has a mouthful of marbles, so it'll sound like, say the word dog. And the patient has to repeat the word dog back. So this helps us to understand how well that patient can hear a degraded speech information. Time-altered speech is another nice test to administer because what it does is it takes the speech and it increases it by 45%. And so this really helps us to evaluate those patients that say, you know, I just can't understand when my professor's speaking quickly, or, you know, so somebody's speaking to me rapidly, I just can't follow what they're saying. So it takes that signal, it actually doesn't distort it in any way, it just speeds it up. And we know that speech and noise is really important to evaluate. It is the #1 complaint among patients that we have. There are numerous tests available, and each clinician and clinic just really has to determine which tests are best to evaluate their patient. Again, you want to make sure you've got sensitivity, specificity data on these tests, but the ones that you're probably most familiar with are the HINT and the AZ-Bio, and while they are used for patients with cochlear implants, you could consider using those for your auditory processing patients as well. And you know, even if you don't have access to all of these tests, you could do just an old school W22 in noise with a +8 signal to noise ratio and see how that patient's performing. One test that we do use here quite often is the Listen-S test. This is listening in spatialized noise. It's a pretty wild test. You actually hear in different spatial scenarios, and it's quite challenging, and it's proven to be a nice test to administer our patients. That test is actually available through Phonak, through one of the manufacturers, but was developed by Harvey Dillon and Cameron out of Europe. So, I mean, the recommendation universally is that at a minimum, a speech and noise test be performed on patients with complaints of hearing difficulty, whether they have hearing loss or not. And I would just get you to think a little bit about cochlear implants. You know, many years ago when we were implanting patients, it was those patients with severe to profound impairment based on the audiogram. But how do we evaluate patients now? Well, we evaluate them based on their performance and noise, right? So why are we not taking that same approach with other patient populations? We're relying solely on that audiogram to tell us if a patient has normal hearing or not. When we're only looking at degree of deficit, we're actually ignoring function. And so I would propose to you that you consider more speech and noise measures in your clinical protocols. Temporal processing, we won't spend too much time on this, but this is a very important area to evaluate, and it looks at our ability to analyze acoustic elements over time. So how quickly and rapidly and how small of a change in auditory stimuli can we actually detect? There's two main categories that we can evaluate. That's temporal ordering or temporal resolution. And we do that through patterning tests and gap and noise tests. What you'll find with these patients is you can almost predict who is going to have a temporal processing deficit. They have very poor musical skills. They have a very flat emotional tone, and they'll have difficulty understanding timing. So whether it be in poetry or jokes, those sorts of things. I will tell you, the one patient population that will not have a temporal processing deficit, or really an auditory processing deficit for that matter, are musicians. So if you have a concert pianist coming to you with these complaints, it's highly unlikely that they are going to have a temporal processing deficit. And I would be surprised if they had any kind of an auditory processing deficit. They're more likely to have peripheral involvement, potentially because of noise exposure. So in the frequency pattern test, you actually present the patient with 3 tones, and they're either high in frequency or they're low in frequency. So they are high frequency stimuli are 1122 hertz, the low are 880 hertz. And the patient is just instructed to repeat the pattern that they hear back. So they may hear, I wish my sound was working, but they may hear beep, 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 and they would just repeat high, high, low. You can see again, we don't have norms for 7-year-olds, this is even challenging for 8-year-olds, and adults can only perform at 75%, so that's a challenging task. Duration patterns are very similar in that there are 3 stimuli presented at a time, and they are either short or they are long in duration. This is a pure temporal processing test. So the frequency pattern test does have that frequency element in it. It can be a little easier just because they can use that as a cue, but this is a pure temporal processing task. We actually cannot perform this on children, and even adult normative values are only 70%. However, I will say if a patient has a deficit in this area, it's highly trainable. Gap and noise tests, we're just presenting 6 seconds of white noise and their gaps presented, and the patient has to click their response button whenever they hear a gap. Normative values for this are in the 5 millisecond range, and so anybody who cannot detect gaps below 8 milliseconds, that is considered abnormal. And this is just when we created this test, this is just the normative ranges. So you can see here around 5 milliseconds is what most individuals come in at. And then individuals with brainstem or cortical involvement really struggle on this test and are highly abnormal. And so here, this line here, this is our 8 millisecond cutoff. So it's a pretty sensitive and specific test. So when it comes to interpreting these tests, if you're interpreting the behavioral test, we want to use a norm-based interpretation. So we do have normative data on all of these tests. Abnormalities on one test is we cannot make a diagnosis of an auditory processing deficit unless it is more than 3 standard deviations below the normal range. And if that's the case, you probably want to administer some other test or repeat that test on another day just to make sure it wasn't a fluke. And you have to be really cautious of depressed scores across tests. So if both ears are doing poorly across all tests, I'd be concerned about motivation or attention, or if that is actually the case, I would send that patient, if you rule out those other factors, for imaging pretty quickly, because that would suggest that there's some significant central auditory involvement that could be neurological in nature. This is how we plot out our data here at UK. So anything in this gray range is within the normal limits, and we plot it by ear. So it's a nice quick way for us to determine if something's normal or abnormal. And we have this across all ages. Again, while a lot of audiologists are not comfortable doing some of these electrophysiological procedures, if they can do an ABR, they can do some of these other tests as well. And so we do recommend implementing OAEs, and if you're able to, some of the middle and late auditory responses. And we'll just look at those really quickly. We can do auditory brainstem response, which we're all very familiar with, on infants through adults. I would also encourage you, if you're going to do these evaluations, to look at the middle latency response. This is actually gives you information about the thalamocortical connection in the primary auditory cortex. If your clinicians can do an ABR, they can do an MLR. It takes just a few minutes longer. You can use the same electrode array. Rather than looking at waves 1, 3, and 5, we're actually looking for NAPA waveforms, and we're comparing the amplitude differences between the two. And then the NA is the first major trough that you'll see following the ABR. You do have to change your filter settings, but I'm happy to talk to any of your clinicians who have any interest in performing these. And this is just an example of ABR that we obtained in our clinic on a patient, and then also an MLR. And it takes about 45 minutes. It really doesn't take that long, but you can see these are nice responses on this. This is a normal patient, but we see that NAPA waveform complex here. And this here is actually wave 5 of your ABR. So although this is primarily focused on the audiological evaluation, we can't forget about the otolaryngology examination. So it is a multidisciplinary team. We work closely with our otolaryngologists. You need to be prepared to evaluate that patient and to rule out retrocochlear involvement if it's suspected, and to obtain imaging when it's indicated. And then also have other specialists that you can refer to as needed. Our primary referrals are to neurology and to speech-language pathology. And I should have also added psychology to this as well, especially if we have a patient, whether it be a child or an adult, that we suspect has ADHD and not an auditory processing disorder. So how do we manage these patients? This could be another 3-hour lecture if we get into this too much. So I'm going to give you the quick 30,000-mile overview. Deficit-driven therapy. I alluded to this earlier, but we want to provide them with therapies that are specific to the area of weakness that they have, and intensity is the key. If they're going to do therapy, whether it's in your clinic or at home through some computer programs, etc., they have to be willing to commit to it at an intense level. So for us, we recommend 2 to 3 hours of therapy a week for 4 to 6 weeks. And that can be challenging for our adult populations. And so what we have found to be the most beneficial in our adult populations is mild gain amplification. And you're going to say to yourself, well, why? They have normal hearing. If we're providing mild gain amplification, it's not so much for the amplification, but it's the technology that those hearing aids afford us. And so the directional microphone technology, digital noise reduction, Bluetooth technology, and remote microphones are huge for these patients. And almost all of our adult patients get hearing aids with this technology, and none of them return their hearing aids. They report significant benefit. They don't have the fatigue at the end of the day because their listening effort is reduced, and they don't have the headaches at the end of the day. So this is something to consider. But of course, I wouldn't put hearing aids on your adults unless you actually diagnose either peripheral hearing loss or an auditory processing deficit. I want to talk about just a couple of populations of patients that you may want to consider, using an auditory processing battery on. This was a study that Dr. Bush and Jones and I did a number of years ago, where we actually looked at patients with small acoustic neuromas. And we know, MRI is gold standard, but not all patients can undergo an MRI. And we know that sensitivity specificity is good for medium to larger acoustics, but it's pretty poor for small acoustic neuromas. So we wanted to see if we could actually use our processing battery and our other indices to increase the sensitivity specificity if we have a patient that actually can't undergo an MRI for whatever reason. This is a paper that we published. We did a prospective analysis of patients with small acoustics who were untreated. And we did our traditional pure tone audiometry on them. And then we also did, we determined what their threshold was for the click stimulus, and we compared that with their evoked potential threshold. And we also did a traditional neurodiagnostic ABR on these patients as well. And then we put them through an auditory processing battery. And what you can see in these patients, actually, most of them had abnormalities on the gaps and noise tests that I showed you earlier. The frequency patterns and duration patterns tests were just not as sensitive, but most patients had difficulty detecting those small gaps in the stimulus. If we actually look at our traditional ABR indices, so that 1.5 difference, the interlatency difference in the absolute wave 5, those were really poor in these patients. So that's, this falls in line with the reported 50% sensitivity for small acoustics. Now, this is where it gets interesting. If we actually perform a threshold ABR, not just a super threshold, and we compare where the patient reports that they hear that stimulus versus where we actually measure it electrophysiologically, there's a significant difference between the disease side and the non-disease side. And so we actually in our clinic use a 25 dB difference. We use that as our cutoff. And if there is a difference more than 25 dB between the patient's electrophysiological threshold and their behavioral threshold, we consider that abnormal. And so if we actually do a 2-test combination, we find that we increase the sensitivity specificity significantly. And so if you look at, for example, using the gaps and noise test with our threshold, actually any of these behavioral tests, we would have detected acoustics in all of those patients. So kind of thinking outside of the box and seeing how we can improve our sensitivity specificity of our traditional tests in isolation. Another patient population I want you just to think about are actually patients who do have peripheral hearing loss, but think about auditory processing in your hearing aid users. We always tell patients that 2 hearing aids are better than 1. This actually might be contraindicated. Jerger has done quite a bit of work in this area, and we actually see that patients who have asymmetric word recognition have poor word recognition when they're binaurally stimulated. So patients who may be rejecting their hearing aids because of issues like this, you might want to consider auditory processing in those patients. And you could do some of these measures in them to see if you're detecting some big asymmetries that would indicate that maybe 2 hearing aids aren't better than 1. And this really comes down to what we call binaural interferences. So we know that 2 hearing aids, for most patients, they improve localization and they improve your ability to hear noise, but there's a number of reports that in about 8 to 10% of our hearing aid users, they actually experience a binaural interference. And so if they're reporting to your audiologist or reporting to you that, they just are not doing well with both of their hearing aids, maybe have them extend their trial. Try one aid and then try the other aid and see if they might be actually experiencing binaural interference, especially because in some of these patients, they may even have a tiny little lesion that's not been detected that could be causing significant issues. This is an interesting case by Schoflin. So when you have these slides, and you may actually even want to pull this, but this child had really adverse behaviors when they were listening with both hearing aids at once. But when they pulled one off, the patient did okay. And basically 1 ear was at 90% word recognition. The other was at 36. And when they were bilaterally aided, it was at 56%. So it's causing significant distortion and interference in this patient. So just kind of keep that in mind. Veterans are another population we need to consider. There's a lot of literature coming out of the VA right now demonstrating significant deficits in the patients who have had blast-related injuries. They often will report that they are having difficulty hearing. Again, their audiological evaluation is normal, but when these patients have been examined and reported on, they actually have significant central auditory involvement. So for any of you that work at the VA, this is really something you should be familiar with and refer them for an auditory processing evaluation. They're not trying, they're not all trying to just get disability for their hearing loss. They have some real problems going on. So we'll go through a couple of case examples. This was an outside otolaryngology referral that we received when I first started here about 15 years ago. This patient had been to a number of audiologists and reported difficulty hearing. The audiologist, this was the audiogram that we obtained from the outside clinic, and the audiologist said, let's just continue to monitor hearing, and the otolaryngologist sent this patient for a neuroauditory evaluation. She was a 49-year-old female with a history of migraines, intermittent facial weakness with these migraines, and a history of learning disability. She's an OR nurse, and that's where things get real complicated, because if you have any difficulty hearing, think about the environment that you're in. You're not only, you have a lot of operative noise going on, but then you also are wearing a mask, which eliminates any visual cues that you might rely on and changes the acoustics because of the filtering properties of the mask. And then you often will add music on top of that. So this is a very challenging listening environment, not only if you have normal hearing, but if you have hearing loss or an auditory processing disorder. The primary complaint of this patient was that she had difficulty hearing out of her right ear, and she had told every provider that she had gone to that there was a problem with her right ear. So she came to us and we repeated her audiological evaluation. And this is what we found. Her left, actually both ears are within the normal range. So we use 20 or better as normal in our clinic. Both ears are normal, but we didn't have that symmetry that was in the other audiogram. So we see a 10 dB, 15 dB asymmetry across the range. So that was concerning to us, especially because she had present and symmetric OAEs and normal word recognition. So we performed an auditory processing evaluation. We did both behavioral testing and we did an ABR, and I was suspicious that she perhaps had a vestibular schwannoma. When we evaluate her, we see that she has a clear right ear deficit on filter words and dichotic digits that we don't see in the left ear. Remember, she complained that she could not hear well out of her right ear, and she also had an absent wave 1 on the right side. Otherwise, everything else was unremarkable. Red flags, right? So we need to get some further testing done. So I referred her to Dr. Jones, and he did a neurotology exam, which was normal. And we decided she needed to have an MRI based on her audiological test findings. So there's no mass lesions, no vestibular schwannoma. However, on imaging, we see here that she has a pretty significant AICA syndrome or vascular loop syndrome on the right side. So this is likely what was contributing to all of these complaints that she had. So this right-sided vascular loop was identified. If you're not familiar with this, this is described by Jeanette in the mid-1970s. Often gets misdiagnosed for Meniere's disease because it has very similar symptoms, but it compresses on that 7th, 8th cranial nerve complex, which really explained a lot of the symptoms that she was having. We published this case study. Surgery was recommended. It was something to consider. She chose not to undergo surgery. So we recommended mild gain hearing aids and some speech and noise training. This was actually because of this patient, it got us to thinking about what happens in the operating room, what happens to our auditory processing. So we actually published this in the American College of Surgeons, where we looked at how do surgeons and residents do listening in these different situations. And we found that certainly when there is music present, that if the stimulus is lower in predictability, a sentence that they might not understand, that they were potentially only going to understand 70% of that when there is music being played in the operating room. So if you have any interest in reading this a little bit further, and then also if you're tasked, so if you're just sitting there listening, you do okay, but if you're tasked and you're during a surgical task, your ability to understand what's being said actually declines as well. I'm going to skip through this case just for time, but this was another patient we identified with a vascular loop, and we actually went through training, and we see after training they had huge improvements in their processing following training. So this was an adult patient that did well from training as well. We are got about 5 minutes left. I'll go through this case pretty quickly. This is an 18-year-old female. She's a competitive swimmer, high academic performer. She actually had a significant history of middle ear involvement. She ended up with a right-sided TM perforation with a mild conductive loss that was successfully treated with a right tympanoplasty. Her hearing returned to within normal limits. So this was back in 2015. She was discharged from the practice and was just needed to follow up PRN. So she comes back in 2018, and then there's no middle ear involvement at that time, but she was reporting significant difficulty hearing and noise. She had had a number of concussions, one which resulted in a loss of consciousness. She had fallen off of a treadmill. She had developed really bad migraines. She'd had imaging workup, which was unremarkable. However, we decided it was probably appropriate to do an auditory processing evaluation on her. This was her hearing loss her hearing in 2018, no loss there. So we can see here she had a right-sided deficit across test results. So she actually came in and did therapy in our clinic with us. We worked on an integration therapy and some closure exercises. And we also put mild gain amplification on her, and she did incredible following training. We can see improvements. This 0-2 are her post therapy results, so significant improvement. She loves the hearing aids, and she noticed a significant difference between the combination of the two. So I'm just going to give you two take-home messages from this lecture today. One, normal thresholds does not mean normal hearing. And so if a patient is coming in with clear complaints and you get a normal audiogram, we're doing a disservice to our patient if we do not investigate that further. And that second take-home message is the audiogram has significant limitations. It gives us information about the type, the degree, and the configuration of the hearing loss. It gives us very, very little functional information. And so I always kind of want you to have that in the back of your mind. It is an important tool, don't get me wrong, but it does have limitations. And if you want to read a little bit more about some of the limitations and challenges with the pure tone audiogram, this is a paper we published in 2017, review article. So those are the references, and then I know we are close on time, but I think I've got 2 minutes if there are any questions. I don't see the chat coming up. Sarah Lynn, do you have a chat that you can see? I just see the Q&A.
Doesn't look like anyone has
Okay.
has any questions right now.
Okay. Well, there's my email address, guys. If anybody has any questions, I'm more than happy to answer them. Feel free to reach out to me. Thanks for listening.
Thank you so much.